for coming to the CHEP seminar this week. We have Orgul Ozturk here visiting us from the University of South Carolina. She's an associate professor of economics there. She is a labor and health economist who does work on labor market regulations, employment programs for the developmentally disabled, child cognitive development, and has done some work on minimum wages as well. Her work has appeared in such journals as Industrial and Labor Relations Review, the American Journal of Health Economics, the Journal of Policy Analysis and Management, and the Journal of Human Capital, and she's here today to talk with us about some of her SNAP research. So welcome.
Thank you. Thank you for the invitation. It's great to be here. Such a lovely campus, beautiful city. This is my first time in San Diego, and so far it's been great. Thank you for your hospitality. Yes, this is the fourth or fifth SNAP timing paper I wrote. I am guessing we are probably to the end of this line of work. I do really like the SNAP timing. It's very dear to my heart for multiple reasons. One, the data in this type of work we did has been great. Wonderful administrative data with very clean identification, source of identification. Plus, most of my research, as you can see, deals with marginal populations, individuals who are at the fringes of the society, who are disabled, who are financially constrained, who are not equally treated. So I do love working on STEM, and here specifically about the emergency room use or health access has been, it's a very, I'm hoping you'll enjoy it too. It's been very fun to work on. I mean, fun. All right, so this is a co-authored work with Chad Cotty and John Gordonier, who happens to be not only a colleague, but also my significant other. Oh. Yes, I mean, confuse people by not sharing the last name. All right, so I'm going to, for 9 slides or so, I'm going to give you a lot of motivating literature. And hopefully you'll appreciate it. I know I usually don't talk about literature much, but here, not only it frames the question, but also it gives you hopefully a prior that I want you to have so I can break it, okay? So we are going to talk about all related to literature, related to SNAP, related to food insecurity, related to healthcare utilization and health status. And then we're going to see how our story fits into this, and hopefully then we're going to see why I find this question or why I find this research interesting, and hopefully you'll do so as well. All right, so first area of research I'm going to try to cover, again, this is not deep literature review, is going to be about food security and health from the health outcomes kind of perspective, all right? There's been a lot of research, there's a lot of research out there that looks at food insecurity and health outcomes such as anemia, diabetes, asthma, hypertension. People who are food insecure tend to suffer from these conditions a lot more than people who are not. All right, so these are not econ papers, these are from the medical and public health literature mostly. And then there's the increased stress. I mean, obviously, when you're not able to feed, or you remember the food insecurity questions. Have you gone to bed without any food in the last 30 days? Or have you ever skipped meals? That is a stress-inducing event. And that has also been studied. There is evidence of association with poor mental health and undesirable behaviors, like behavioral issues in children who are in fragile families dealing with food insecurity. And there's also some more familiar papers from the RO literature, complications with pregnancy-related outcomes. Okay? So this is food insecurity and health from the outcomes perspective. Then there is the food insecurity and health from the healthcare utilization perspective. Again, this is more about constraints, financial constraint side of the story. So it's been shown that it is, food insecurity is associated with postponing of medical care and medications, or non-adherence to costly medications. So if you are struggling to make the ends meet, if you have to choose between medication, refilling your prescription for hypertension, and or putting food on the table, feed your kids, you are going to probably opt for not filling your prescriptions, which may, as a result, change the, since we're interested in ER utilization, this mechanism may work through the lack of access to medication that is required to keep your condition in check. Okay? So that has been shown as a result of increased ER use and hospitalization among the food insecure. Again, this is either through these mechanisms or by itself through the health outcomes mechanisms. We see higher emergency room use and hospitalization among the individuals who are food insecure. Again, these are mostly coming from public health literature, more from the medical literature. And from very survey-based work, where they go to the emergency room and ask people if they are food insecure or not. All right. So I know most of you know a lot about supplemental food, supplemental nutrition assistance program or food stamps program. But I'm going to give you some background, so before I move on with the literature that relates to SNAP and food insecurity and SNAP and health outcomes. So food stamps program, or SNAP with its new name, is a federal program, okay? And the goal is to alleviate food insecurity. And it is assistance to low-income families with money that is only for the purpose of purchasing food, designated food. This is a federal program, but it is run by the states. All right, so this is going to give us our kind of identification source. In a moment, you'll see how. Especially with the welfare reform from Provera after all in 1996, certain things change with the program. And most importantly, at least for our purposes, has been two things. One, the fact that now, after 1996, especially after 2000s, most of the benefits started to be distributed, along with other types of benefits as well, through electronic benefit transfer cards, EBT cards. So these are no longer stamps. You do not get physical stamps. You don't have to go somewhere to retrieve your stamps. Instead, your benefits are loaded into your card, debit card, the account that is connected to, when you are supposed to be receiving these benefits once a month, and it just appears, according to South Carolina people, at the midnight of your benefit receipt date, it just appears in your account. That is, the administrators told me. I don't know if it is verifiable by the recipients of the program. Yes.
How were they, when they were sort of the food stamps? How frequently were they distributed?
Again, it was once a month.
Okay.
But I'm not 100% sure the logistics of these things. I never had a chance to actually study stamps version of food stamps. Since I started working on this, it's been always in this kind of format. All right, once a month, again, run by states, distributed right now with electronic benefit transfer system. Why am I emphasizing states? Even though it's a federal program, states had some flexibility on how they can run their program. For example, they were given some flexibility in terms of how often they want to recertify people, or if they want to exclude car ownership from the restrictions, the assets, etc. they can own. In the original program, if you own a car, you are not eligible for food stamps, or if you have certain amount of savings, you are not. But in some states, states can choose to be a little more generous in these dimensions. And actually, those dimensions have been used a lot as the instruments, IVs, for most of the research before the timing type of research came into play. But the most important thing is the distribution schedule is determined by the states. I'm going to show you now what I mean by this and how much of an issue is this. Can everybody see this? This is just a little snapshot of a long table that's just the half of one page. You can see it varies a lot by state to state, and also it varies across time in any given state. All right, so let's look at California. It is 1st to 10th, just like Columbia, just like South Carolina. Illinois is an interesting one. Up until 2010, they were distributing on the 1st, 3rd, but nothing in between until 8th, and 11th, 14th, 17th, and then 21st, 23rd, and just switched a little bit. They started distributing in some in-between days between 3rd and 8th as well. So, you know, it has been very different across states and also across time in some states. Yes.
So is there budget-related reasons why they're doing
No,
this?
the original proponents, I guess, of this policy were actually the grocery stores, supply side store. That is, they were having difficulty, one, the supply chain issues, stocking. The other one was having enough personnel those days. Because you'll see in a moment, we're going to talk about this, when food stamps are received, they're almost immediately spent. So there was a rush of influx of food stamp recipients to the grocery store.
When you say it's distributed between the 1st and the 10th, let's say, do we have a sense of the distribution that's there? Is it?
So if I have a dash, oh, you mean
So I mean, it's
distribution?
between the 1st and the 10th. Is that
So how many of them are getting in the first? How many?
first versus the 5th versus the 10th?
So it depends on the type of which state you're looking at. In South Carolina, you'll see it is equal, it's very random. In some state, this is with first letter of your last name. Okay, in that case, that may not be as so. But any state, I think that relies on, like in South Carolina, it is about your case ID and last digit of your case ID, and or social security numbers and either beginning or end of it. Depends on the state, they have different rules, but the idea is to, I think, as equally distributed as possible. The only thing I am thinking is in West Virginia, for example, where it is the first letter of your last name, it may be more in the A's, in less so in the W's, I don't know. Yeah, that is depending on the state. You're right. But if there's a dash here, if you're just thinking about technically, it means every day in between. Not necessarily equally. Very good.
So just try to understand the signing mechanism a little better. So they're pretty random. They're dropping the stamps.
Yes,
together.
exactly.
Not
Exactly.
because you're getting a lot of money, you're going to get the money first. Or say you're getting more money from SNAP.
Yes.
Is that possible you're receiving this?
Oh, no. You mean you're getting more money because you have a bigger household,
Something.
you are going to be one of the people with the earlier dates? No.
Yeah, okay.
I may be generalizing it for other states that I don't know enough about, but nothing we know suggests that exists such a system. Okay? Yeah.
And then is it like within year at the same families receiving on the same day? Like,
Yes.
So you're always getting on Tuesday?
Except New York and some other states, they have some varying schedules within the year, but actually almost always exclude, it's not here. New York from the, in certain boroughs, etc., it was different. And in some states, I think Philadelphia was one of them, in certain counties, it was also changing in not so relatable, or we couldn't make sense of it, and it was, but if you are in any of these states, if you're receiving on the 5th, you're always receiving on the 5th, yes. But if you're in one of these states that kind of changes things, it may be different in
Right.
weird fashions. Okay, all right. So this is, I wanted to show you so you can kind of see where I'm, coming from. And why I am excited. Okay, what happened?
You went to the end for some reason.
Okay. Was supposed to go back to that slide. All right, this is, quick look at the presentation. All right, should I go one more? Okay, this is the last slide we were on. All right, so when I talk about now benefit cycle, you're going to think about all those different distribution schedules and how it implies a different month, benefit month, than the calendar months. Okay, so when I'm trying to talk about benefit cycles, I'm going to refer to your receipt date, that's day 0, and the whole month between your two receipt dates. You do the two receipts, okay? So SNAP benefit cycle and smoothing is also another thing that's been studied. I've got some, I got in trouble for saying fail. I'm going to say we're not able to, or have, let's just stick with fail for now, okay? SNAP household failed to smooth consumption, okay? And it is through financial constraints. They do not always have equally distributed consumption over the course of the benefit month. When the SNAP benefits are received, they're quickly spent. We just talked about it. And it's been documented in several econ papers, one of us being ours. This one is our paper. And we show that as soon as the benefits come, in the first 3 days or so, most of the grocery shopping is done. I mean, this is not individual level data, this is not administrative data, this is our paper at least, and all of the others as well, from data that is either survey-based, and ours being Nielsen data. So you don't necessarily know if somebody is a SNAP recipient, but from their income and household composition, you kind of can infer they are eligible. So this is intent to treat and how it relates to their behavior, in grocery shopping behavior, at least in our paper. Okay, and then we also know it's been, again, a theme that comes out of this literature a lot. Single monthly treatment seem to leave some nutritional deficiencies, okay? And we, in every single paper we wrote, we always try to bring this in. Maybe we should distribute it differently. Maybe we should have it twice a month, not once a month. Of course, that needs to come with maybe increased amount of benefits as well. But somehow, when you distribute it once, especially you'll see later, if that once happens to coincide with the beginning of the calendar month, with all the other income transfers, I'll talk about it at the end of this talk, that seemed to leave some nutritional deficiencies at the final weeks of the month, both calendar month, if they align, and if not, through the at the end of the benefit cycle, the benefit month. Okay? And you know Shapiro's paper, it shows 15% decline in caloric intake, and this has been shown, this not only for SNAP, this is the SSI benefits, but any benefit that you receive once a month, and for financially constrained families, is the benefit cycle leads to, towards the end, some reduction in consumption. All right, and another paper, a recent paper by Christian Gregory and I can't remember Smith's first name, those two wrote a paper which basically shows likelihood of an individual being classified as food insecure, someone who is on SNAP, being classified as food insecure increases towards the end of their respective benefit month. All right? So this is the literature that is getting at benefit cycle and smoothing story and how it may relate to. So remember, we are going to study ER use, right? Healthcare outcomes. So all I'm giving you here is all different mechanisms that we may think of having some health consequences. So far we are thinking about food, nutrition, food insecurity, stress, or just deficiency of nutrition. And just think about what the implication it might be for the ER. So you're all thinking now increased ER use at the end of the month, right? Okay, keep on thinking. All right, so the other thing that we know is you die for all sorts of reasons more, actually for all reasons except cancer, you die more at the beginning of the month. My husband loves teaching this to undergrads. He's like, be really careful, guys, at Halloween. His Halloween lectures. Basically. Tomorrow, you may be scared tonight, but you should be scared of tomorrow morning. So you are more likely to die at the beginning of the month. All right, so there's papers that show first few days of the month, you die for all sorts of reasons. There's also papers who show increase in drug-related hospitalizations, mortality. So you're kind of seeing this influx of money may lead to some behavioral responses that are not desirable, or increased financial activity or financially motivated crimes may be leading to that too, which in a moment I'm going to talk about. So there's also this other papers that show as soon as these social security income or military payments, tax rebates, etc. is received, there is increased mortality, and this is most pronounced among liquidity constraints. Okay? There is also a huge literature on, most of it recent, on benefit cycle and behavior. Right? So there's two sides to the story. One is benefit cycle duration, and some recent papers here, and you're gonna hear Annalisa talking about something different, but this is one of our recent papers, and they do find increase in financially motivated crimes later in the public benefit months. Okay, actually, it's kind of when they are short on cash, I guess you can think of it. And there is increased student disciplinary incidents towards the end of the benefit cycle again, when they are farther away from their benefits dates. This is among the elementary and middle school students from North Carolina. And we do find something similar, or we relate test scores to SNAP cycle and kind of think about similar mechanisms, either through behavioral issues or health-related issues. We find that towards the end of the benefit cycle, students perform much worse than they do when they are closer to benefit dates. Okay? So again, we are thinking about here some kind of smoothing story, maybe some kind of behavioral response to benefit cycle, things happening differently. The other behavioral response is about the treatment day, the day of the receipt. So that's what I mean by treatment day. We talked about this large increase in grocery shopping, so a lot of economic activity. You are out and about. This may mean something. And these are the papers we previously looked at. And then we ourselves showed, so in an kind of opposing way, we showed reduced drunk driving fatalities. So the first one you can imagine may be resulting in more economic activity, more people driving, more people out, and so maybe as a result getting hospitalized more. But then our paper, we are showing reduced fatalities on the receipt dates, and actually we do relate those two to each other, because I think it is more people are eating at home, not out, and they are drinking better at home as well, and getting in less trouble. And this is something that came out of that 2006 paper we had. Okay? So you have all sorts of different literature now that has some implications about how this benefit receipts, how this income, influx of income may, through either mechanisms that you expect, food insecurity, etc., or through behavioral responses affect the emergency reviews, right? So these are the questions we are going to ask. Does the SNAP benefit cycle impact ER utilization?
If you don't use your SNAP benefits, like you don't use all of them in a given month, do they roll over into the next month?
No, and I don't think that is really a concern for any of these families. This is not a lot of money you're talking about.
Right.
And you do, first of all, not all eligible people get their SNAP benefits. I think really desperate ends up getting really in need. And as a result, we're talking about a very small amount of money. It's not going to be enough to kind of roll over to another month. I don't think it is that much.
Is this, so from this literature that you know sort of super well, is this bad planning? Is this myopic, or is this optimal rational behavior in terms of distribution of?
So Shapiro basically says hyperbolic discounting is myopic consumers in some ways, right? On the other hand, I mean, you kind of think, hey, you know how much you're going to get, then it must be bad planning. But on the other hand, it may be rational as well, because if you do not spend it now, there may be some shocks, that, and it happens, I think, a lot for the vulnerable groups. That is, going to have a claim on it anyways.
Right, and so, I
So
mean,
it may be rational.
right, and one wonders whether some of these bad outcomes that are happening later in the month that you observe, right, are
We're going to happen
avoided.
regardless.
Well, yeah, and could I guess we'll talk about
Yeah,
whether something
exactly.
else could sort of be avoided by the rational choice to sort of consume more early on.
Yeah, no, I mean, I definitely agree. Hopefully the way we are handling this, the way we are analyzing this, is going to be immune to such concerns. It was going to happen regardless, however, we really identifying this effect. But because we are only going to be looking at these individuals, and the only thing that's varying is going to be this distance. All right, yeah, no, that's a very good point, though. And that's why I get in trouble for saying fail. It's not necessarily failing. I don't know a better word to capture the situation. If you have a suggestion, that's not gonna. I always play the foreign card in this kind of situation. But if you have better suggestions, I'm open. Regardless, but yeah, I don't think that's an issue though. The lack of spending. So we are going to try to answer. Does the SNAP benefit cycle impact ER utilization? And we are going to try to understand two different sources, two different types of mechanism. One is long duration effects, being inability to smooth, being away from that influx of nutritional nutrition, and unable to fill medications, etc. type of mechanism, and then the treatment day effects. Whatever else is happening, increased mortality day rates, increased economic activity, etc. So we are going to try to understand how these are going to affect emergency room use. And I think all of you are thinking now, every story I told you kind of implies, one, long duration is going to really increase emergency rooms, right? And possibly, treatment days as well, going to increase emergency room use. All right, so let's see. In a moment we're going to see. SNAP timing in South Carolina, let me talk about it first. To one, convince you that this is a random assignment, so a nice exogenous variation through which I can identify some causal links. So 10 distribution days in South Carolina before 2012. It was the first 10 days. Depending on the last digit of your case ID, you received it either on the first, second, third, whatever. If it is 0, it was the 10th. After September 2012, it became every other day, only for the new clients, every other day between 2nd and 19th. Everybody who was still in the system continued to receive it on their days. If they got renewed, then they switched to the new system. That's why we kind of ignored this group for now. Even though we have data past 2012, it is really hard to identify who's new, who's not, and just knowing the end of their case ID wasn't enough for us to identify certain things. All right, so it is assigned randomly, and I'll convince you to that in a moment. Last digit of case ID, and this is the distribution. This is all the SNAP households, and this is first 10 days, the share of the SNAP recipients receiving their food stamps in those 10 days. Okay, so pretty random, and
Do you know in the literature, is there any evidence of benefit diversification? Like, if I get it on the 1st and my neighbor gets it on the 10th,
yeah.
am I going to share with them?
I think it is probably happening a lot, especially in Black communities. This, support networks. I don't think there is any evidence, and maybe you can study it in a state like West Virginia if you know who lives where, and the last names of the neighbors. It can be really interesting. I should tell this to Patrick. Study. All right. Okay. No, excellent idea, and it can be really interesting to be able to see that. There's a lot of, I think, anecdotal evidence of these stories, especially in sociology literature. You see a lot of the sharing of SNAP benefits, and some of the mechanisms we are thinking about comes through that, actually. People who are not eligible or who are not the recipients benefiting from the receipts, but no, there's no evidence of that. All right. So we have a administrative data from South Carolina, which is link data that is established by RFA for us. RFA is a state agency that's all job is to house administrative data, clean it, and then link it, de-identify it for research purposes. They also prepare reports, but I love RFA people. They may have mixed feelings about me because I constantly annoy them probably. But they nicely merged Medicaid data for us with the DSS data, Department of Social Services, who manage the TANF, SNAP, etc., and all sorts of other programs for the individuals who are in need of financial assistance. Okay, so we have Medicaid data and DSS data. Medicaid data has the portion that we end up getting has all the emergency room information, emergency room department visits for everyone who has been on Medicaid for more than 3/4 of the year, which happens to be most of the Medicaid recipients. And we know all of their demographic characteristics, all sorts of demographic characteristics, their Medicaid qualification reasons, and diagnosis codes. Okay, so we know why they went to the ER. From DSS data, for all of these Medicaid recipients, we know their SNAP status at the time of the event, the incident. And we have, for those people, their receipt date, their last digit of their case ID. And as a result, we can calculate days since receipt. So we can potentially, actually they first gave us this, and this we have for everyone, even the ones who are not currently on SNAP. So this is this measure, time since last receipt in our data, is from -infinity to +infinity in theory. I think I'm going to try to use that at some point too, not current, but at some point recipients. But for now, we are only concentrating on people who are currently on SNAP and utilizing this time since last receipt as well as their receipt day information.
So what proportion of SNAP recipients are on Medicaid?
All right, so a huge portion. I think it depends on the age group that you're looking at, but it was 67 to 75, depending on what year you're looking at.
Okay.
Around the Great Recession, even though SNAP recipiency rose significantly, Medicaid doesn't qualify in the same way. So when they increased the generosity of the food stamp program for a couple of years, there was a lot of marginal entry. They were Medicaid recipients, but now it's kind of normal to 67 is what the normal rate is.
Do you know the SNAP recipients renew schedule? Like, if the SNAP one expired, they may want to go to the hospital before it actually.
I mean, I can see them in the data.
You can see.
But if you are thinking about, is the problem you're trying to think about is that turnover issues and the time between recertification when you may be most vulnerable.
Yeah.
We actually, one of the reviewers brought that to our attention, was worried about it. We received some extra data by placing this Freedom of Information request, and they gave us all sorts of, this many people recertify before their benefits expire kind of information. And actually, only about 5% had that gap, and those gaps weren't that long. So you weren't really. So yeah, that is something I think being documented. A lot of this churning happens in food stamps rolls. At least as far as South Carolina is telling us, it doesn't seem to be a big problem here. Is there any other question? Okay. All right. So this is our data. It was a lot of data. When they first gave it to me, it was at every provider level, 38 million observations, because every doctor, every nurse, every line was a different part of the charge. Once I cleaned everything, it is almost 3 million, more than 3 million observations at the person visit level, coming from 910,000 unique individuals. Okay. Actually, this is one of the reasons that we didn't get the whole Medicaid data and only concentrate on the emergency room, not all health utilization. This data can get gigantic. But we wanted to get a lot of years to analyze. I wanted to have the ideal data was what we had in mind was a panel of individual, looking at their utilization over time, which didn't end up being the way that we handled this, mostly because of the construction of the data, but also with the way the observations are, the numbers are. Okay, but this is the data. Data is great. If you want South Carolina data, I can hook you up with the right people, okay? All right, so what did we do? We lovingly call this paper our T-stats paper, okay? Because pretty much it's going to be that. We first calculated the ER patients observed in each day and the share of these ER patients in each day who are on the long wait part of their benefit month, okay? So you pick someone and we just calculate the share, just of what we observe, who are on the long wait side of things. Then we calculated the people, of course, whenever it is only possible, who are receiving the benefit that day, that we see them in the emergency room, all right? So then we looked at their share in that day among the people we see on that day in emergency room. What was their share? What was the share of individuals who are coming to the ER on their day of receipt? And we also calculated the average number of days since SNAP received for each day. So again, given.
Do we have any sense in South Carolina of and this is going to have to be sort of informative, what share of SNAP recipients might sell their benefits to others?
You can't really, okay, of course you can probably sell the groceries you buy with your benefits, but you cannot really give away your SNAP card, EBT card.
Okay.
There is not, it was I think more of an issue when it was actual stamps,
Right.
but now it is EBT card, you have your name on it.
Okay.
You, I think
Okay.
most of the time are required to also show identification. And or they have a PIN card, I think, because this is more like debit card that works. All right, so, but there's nothing stopping them from selling the groceries they purchase, obviously. All right, but I think USDA has all sorts of fraud, etc. issues. I don't think it really addresses this issue, but it's a very small concern, I think, among purchase analysts. Thank you. All right, so this is what we observe in the data. And then the other side of things is what we would expect to see in the data. All right? So, this is what I mean. This is just an example from August 2005. All right? And remember, there are three things we're interested in. Day of receipt share, long wait share, and the average days since receipt. So the blue lines are share of long waits. On the first of the month, only the individuals who are receiving their benefits on the first of the month are receiving. So only 1/10 of the people are no longer in their long wait, but 9/10 are. So that is why it's 9/10. So this is expected, theoretically. And then 8/10 in the second day, etc. We have no long waits in the middle portion of the month, and then at the end of the month it picks up again. All right? Every other day, another group entering. Long wait, remember, is, probably I didn't tell you that, 21 day or more since receipt. It was in one of the slides, I didn't state it, I don't remember doing so. Okay, and then first 10 days of the month, if I go to the ER, in one of the first 10 days of the month, if I pick someone from the food stamp recipient Medicaid, patients who are in ER that day, what is the expected probability of them being someone who they receive their benefits that day? It's 1/10, right? So these red bars are just showing that. For any given day, among the days that are receipt days, when I see someone in the ER, the probability, expected probability of them being someone who is receiving their benefits that day is 1/10. This is expected. Now, why do we call it our T-stats paper? Because what we are going to do is to compare what we observed, what we calculated from data, to this expected share. We're just going to compare and test if they are zero. Okay, if the difference is zero, if they're equal to each other. Okay, so what is expected, what we observe, are they different? So this is basically the metric we are creating for all those things we are interested in. We call it difference, percent difference. ER refers to the observed value at the ER for whatever the measure we are thinking about that day. Population refers to the expected value of that measure that day. And we are testing if this percent difference is zero, restricting ourselves to the days when that number is non-zero. So for the long weights, we are only thinking about the beginning of the month and the end of the month. For average days, every single day, there is some number to be able to calculate. And for the receipt date, is only first 10 days. Yes?
Sorry, you might have mentioned this, but for the ER admissions, do you know whether or not that individual was a SNAP recipient?
Yes, we do.
Okay.
So our population is Medicaid population.
Okay.
But for everyone, we know if they are SNAP recipient, if they are current SNAP recipient, and how long it has been since their last receipt. So even if they are not current recipient, we know that number. And for the current recipients, we know their receipt dates. Yes, we do know if they are SNAP or not.
So is that true for children? You could know if they're a child of a SNAP recipient?
Yes, yes. And because almost 65% of all births in South Carolina is Medicaid births. Because if you're a low-weight birth, you qualify for Medicaid. Even though you may have another insurance, you show up in the Medicaid data. So we do know their SNAP, and we're only looking at the SNAP. Yes, that is the case. All right. So let's see the numbers. Okay. So I'm gonna first give you the long weight and day since, and because that is most of the literature. That's what most of the literature wrote about. This what happens to you towards the end of your benefit cycle. What happens to you as you move more and more days away from your benefit day. So the numbers refer to the mean proportion expected, mean across all possible different receipt dates. Think about all 10 versions of the case IDs. All right, so long weight share, and this is the expected, is 0.48, okay? And most of it is coming from the February's, not being 50%. And about 14 days is the days since receipt. This is what we expect. That's August graph you saw, think about that for every month, and then average across all years we have. With the leap years, etc. Coding this was kind of not fun. Anyways, and then we have the observed share, and these are the differences. As you can see, even though days since receipt is significant, the number is really, really small. It's not different than what we were expecting. And long weight share, again, is not at all significant, and it is not at all in the direction that you want it to be anyways. Okay? We were thinking if all this that smoothing etc. stories were the dominant story, you would have large positive number for this difference. Okay, it will be much more than what you were expecting. The observed numbers will be.
So I know some of the other literature looking at crime and academic performance probably defines it kind of along the lines of this, but I'm wondering for sort of the conditions you'd be looking at in the emergency room. Even though I got my benefits today, maybe it's going to take some time, a few days of eating well in order to.
Yeah. So you're thinking it for the. So you're thinking even at the beginning of when you receive your, by not thinking of as the extension of your benefit cycle, we may be excluding some. We did look at that. By including day 0 as a part of the long wait. It didn't make a difference. I'll tell you what made a difference later. But yes, very valid concern. You're not immediately going to consume that, or all the household isn't going to immediately benefit from it. Yes, at least if everybody is out and about working, even if you do the grocery shopping early in the morning, that impact isn't going to be immediate, right?
And also to have like a serious impact on your health.
Health, exactly, exactly.
Okay.
Exactly, but that doesn't seem to be the issue. Yeah, we were worried about that as well at some point. All right, the biggest thing, though, is the next now. So this is, all the days that are receipt dates, you expect it to be 1/10, yeah? But actually, the share of people who were were in the ER on the receipt date was only 0.96%. This is 3% difference than what you're expecting, what you observe in the ER. On their receipt dates, people are going to ER 3% less than expected. Okay? So you are not going to emergency room on your receipt date. What is your intuition? I'll talk about in a moment. This is graphically, I think, much more impressive. You see this big dip. When we saw this, because this is not what we were expecting. Okay? We thought we did something wrong. We did it over and over and over again. And finally it was like, I guess this is, and then we started presenting and people were like, this is really, I think, what you should emphasize, because we were mostly worried about not finding anything with the long run, long wait shares. But this is something interesting. Let's dig deeper into this and figure out why this is happening, what is the reason for this dip. So this is again average. Let me explain the graph. Think about all these people, people who are receiving on the 1st, people who are receiving on the 10th. Think about all of their benefit cycle, and this is what their expected share in the emergency room at any given day, and what is their share that is observed, and normalizing that around their receipt dates for all possible 10 versions of these people. This is the picture we get, okay? So this is 15 days before your receipt dates, 15 days after. And you kind of see, maybe, my intuition is like they are delaying it, okay? This is related to that whole anecdotal stories you hear about people using ER for emergency reasons. Maybe this may be it. There are certain things that can be delayed. And you can see maybe they are going a couple days later. And we're going to devote now a significant amount of time trying to see if that is the case. All right? If that is actually some non-emergency use of emergency room, delaying of care, and doing what instead? We're going to try to get at that as well. All right, so let's test that intuition. Are they using it? First of all, let's think about the conditions they're at the ER for. So what are the non-emergent conditions? What are the emergent conditions you can think of? So when we were first trying to deal with this, we tried to use, NYU has this non-emergent use of emergency rooms, an index that tries to get at. But their main concern is preventability. What can you prevent by primary care? What we are thinking about is more like if you're vomiting, it's a true emergency. If you break your arm, that's an emergency. That has nothing to do with the primary care. So that is something we can agree on. But then there are other things in that index that doesn't always make sense. For example, pregnancy-related complications. It is, yes, something that you can probably deal with the primary care. You may think of it not being emergency use, but from a pregnant woman's point of view, if you are feeling it is emergency use, right? So we are going to think about it from the perspective of the individual, what they feel like they can delay. So most non-urgent ER utilizations, again, this is coming from that literature I was first talking about, identifies these as non-urgent use of the emergency room. Respiratory problems, okay, these are common colds, etc. is what I'm talking about. Abdominal discomfort, including urinary tract infections. Chest pain, eye and ear problems. This is mostly ear infections for kids. That's the most common reason for kids to go to emergency room. So as a result, we looked at the ER emergency ICD-9 codes for this, and so these are the codes, and looked at the numbers. Are they getting the, yeah, sorry.
I think chest pain
Yeah.
strikes
So-
me as the exact thing you would want to go to the ER for.
That is
No?
right.
So there's chest pain and then chest pain, and you're immediately
Yeah.
thinking about heart attack.
Exactly.
Okay, but this is, a lot of these chest pains relate to other things too. I mean, people go with that complaint, but that is not usually the diagnosis, right? So you have a chest pain, it may be acid reflux that is causing that. It is not the heart attack you are having. Or it is some respiratory problems leading to back pain and chest pain. Chest pain here, this refers to, I mean, there are subcategories of it. Some of it is, yes, very serious stuff. This is the most general way of looking at that. Okay. I mean, we are here looking at the diagnosis codes, but some of it is just not that, these are not all heart attacks, I should say. That's what I was trying to get at. All right. So what are the, that's the number we looked at before. What are the reductions on the day of receipts for these conditions? And they all seem to fit kind of non-urgent use. So you can see acute respiratory infections, and this is again common cold, etc., not chronic asthma issues. You're not delaying care necessarily for asthma attack you might be having. Ear infections for the kids. And chest pain, that was the biggest one. Abdominal pain, although it's not significant, the number is kind of what we're expecting. And urinary tract infections, they are also being delayed. Again, you're still probably seeking care for this the next day in the emergency room. You're just not going for these cases to the emergency room the day of your receipt. And you're going to see this is going to be different by age groups later. Okay? Who is doing this kind of delaying is different.
Have you looked at urgent conditions as well?
Yes, we did. I mean, urgent conditions, we have all sorts of urgent conditions in the paper, but two of these we kind of feel like is really the type of things we're thinking about. They do not see, we don't see that in them.
So I know sometimes chest pain, like anxiety attacks can present as chest pain. Did you also look at like mental health related sorts of?
Yes, we did. I mean, I don't remember the exact numbers, but you should see them in the paper. I think they are, we have all sorts of conditions in the, yes, right?
Yeah,
Joe?
mental illness,
Yes.
anxiety.
Yeah, because, I mean, we were interested in mental illness and anxiety more with the food insecurity leading to all sorts of issues because we were expecting things. I don't remember now what the signs were, but yeah, they're all there. Most surprising ones for me were actually diabetes, hypoglycemia, hypertension type of stuff. I was expecting, a little more increase in them. That was not necessarily the case, I guess.
So, yeah, this might be where you're going with the talk, so I apologize if I'm getting ahead
No.
here. But given that you find these pretty large drops on kind of the day of, there's a question of, is it the access to nutrition that's making people temporarily a little bit healthier, or if this is just delaying their behavior. And presumably you can test for whether it's a delay by adding up the cumulative kind of over visits in the following days and see if they cancel each other
That's
out.
actually one thing we thought about doing but didn't. And that's not the direction we took. We instead went to ATUS, American Time Use Data, to see, what they are actually doing with their time. If we can see any evidence of change in household activities that can give us some. But yeah, that's it. And we've been hearing this a lot. Hopefully we'll do something in a different paper because this one is already accepted, I think. We'll see. But that is an excellent idea because you see that little bumps, see if that is being picked up and for what conditions it is picked up. We haven't looked at it.
Well,
but
I think that would, kind of the welfare implications and kind of
Yes,
the
exactly.
overall net impacts
Yes.
of this program. I
yes,
think
exactly,
it
on
would be- it'd
the
be
emergency room
informative.
utilization, etc.
Yeah,
If you're
yeah.
interested in, excellent point. This, we were also excited about this finding later on once people started, talking to, trying to convince us to look into the day of impact about this, hey, this may be the evidence of this non-emergent use of emergency rooms. And yeah, maybe in a different paper, I think we should do more about this to really understand, because there's a lot of anecdotal evidence, but there's no real evidence of it, right? And also, we looked like the racial composition of these groups. It's always been presented as a minority issue, for example. It is not. It is equally prevalent among all racial groups. I don't know. Yes, definitely something I think that can be more done about that, and should be done. We should definitely look into it. But I'm not going to be able to answer your question in that way. Hopefully other ways, I'm going to be able to get it.
Alright, since I've been stuck on this whole idea, like the first 10 days, do you know what day of the week that it lands on? So if it could be like a Sunday or a Monday where people aren't supposed to be working or they are working.
Yeah, we did look at that because in the drunk driving paper we were seeing different effects if it was a weekday versus weekend, and also the grocery store paper we wrote, grocery shopping one, because you were seeing different things purchased, different people probably were going to shopping. We didn't see much here, but again, there was enough in the paper, we didn't necessarily exploit those much. Possible extensions, yes. And also, like, another thing that I would love to have in this data is, I know a lot about the visit, but I don't know the time of the visit. You know, is it true emergency? If it is 7 p.m., you are not going to have a doctor's office to go deal with it, right? My kids always chooses after hours to break their whatever. So, you know, I am very much familiar with the idea of use of emergency rooms. But yeah, I think that's a great point. What day it is it Sunday, it is Monday. And I think there will be, in other things, you see a lot of movements within the day, within the weeks of the day. I think there's some interesting things to see there too. Is that what you were getting at?
Yeah.
Yeah, but I don't know. I mean, I know, but we didn't necessarily exploit that too much. Anything else? All right. Okay, so this is where I'm going to try to get at that. What are they doing? Okay, so we went to the Atos data. Actually, Chad went to the Atos data. He was a little familiar with the data, and he did some additional analysis using the time use survey. So this survey it collects a lot of information on what people do at their time through the diaries, okay? It includes, among all other things, time spent seeking and utilizing medical care. This is not only emergency room use, it is all sorts of medical care. And we also know we have the information on the date of the activity. So, and we also know the economic characteristics of the participant's household. And for some years, 2006 and 2008 and 2014 to 16, they also asked if the household is SNAP receiving. Not for all years, but for those years. So we know the state of the respondent, and we can link the Atos's time use measures to SNAP treatment dates. Okay, so we did it for all 50 states, not only South Carolina. And we only looked at individuals living in households receiving SNAP benefits. We cannot observe their SNAP receipt date, so this is more like intention to treat type of treatment we are looking at. So likelihood of treated using the distribution dates in a given state and knowing what your household SNAP receipt status is, we attribute a probability of you being treated on a given day. Okay? So when we look at the data with a fixed effects model, when we have a SNAP bunch of demographic characteristics, time used is the variable of interest here. We are trying to explain here. We're going to look at two activities. In a moment I'll explain what. We have SNAP, propensity of receiving it in a given day, in a given state, household individual level characteristics, bunch of fixed effects, metropolitan area, state, year, month, day of the week, payday, and we also have errors clustered at the state level. And these are the results. We looked at two outcomes, two activities. One is time used grocery shopping, and the other one is time used seeking medical care. Because, you know, our first thing was they must be grocery shopping, knowing everything else we know about SNAP households. And you see average minutes spent in a given day for grocery shopping is about 7 minutes. Okay, and for the receipt days, when the probability of the day being a receipt day increases by 100%, that is 16 more minutes. Okay, so this is for the SNAP recipient households. Remember. So, what about the medical care seeking? They do spend much less time seeking medical care, about 10 minutes less, right? And the average is about 5 minutes. So midterm, yeah, this is, I think, really good. An external validity for our results, I think, giving us some extra support for our intuition that this is a behavioral response. This is not health-related necessarily. It is maybe health care related through the delaying of the needed care, and maybe not overall in the welfare calculations with the extra care seeked in later days, kind of wash out. But at least that day, they are not seeking medical care. Okay?
Do you, in the time you stayed, do you look at all the time spent eating at home?
No.
Well, I mean, you're talking earlier about this one of your
definitely, you're right.
stories,
Yeah.
go down.
We should definitely look at it. You're right. I don't think. I mean, he may have played out of that, but that wasn't ever the results we discussed. No, very good point. Cooking or eating at home. No, because that.
I noticed that you saw a big positive increase in vomiting use at the ER.
You're
And if
thinking.
it's families that don't cook that much, and somebody's.
Is that what you have at home? That issue?
Yeah,
Okay, no. All right, no, that's a great point, actually, yes. Yeah, definitely, that can be another dimension that we see some
It
movements.
would just be more validity for your story.
All right, okay. So, one, I think, important thing is, at least, a lot of the literature, the medical literature I was telling you about, they always talk about certain age groups more, children and older people, because they are going to be more vulnerable to not only these health problems we've been talking about, but also maybe more affected by the food insecurity and nutritional, deficiencies, right? And you may see this more. As a result, we should expect some variation across age groups in terms of the severity of these behavioral responses, or both the long wait results and the day of results. Okay? Because especially the non-adherence to prescription drugs issue is shown to be a big issue for the, I'm not going to call elderly, because this is 55 to 64. Again, another issue I get in trouble with. So I'm going to call them older adults, okay? So for older adults, non-adherence to prescription medication is shown to be a problem. So we expect for them to have more maybe long wait issues. And or, kind of getting at that question you were asking, day of the week, who is doing what, you may see some differences in by age, because not everybody does the grocery shopping, right? Not everybody deals with the medical care seeking. So that's going to be, again, probably different by age group. All right, so let's see the numbers. Our, again, kind of intuition confirmed, I guess. You see the lowest effect for the kids. You're not delaying your kids' emergencies. If they need to go to the emergency room, they do. And you groups that you see this effect the highest are the people who are more likely to be doing that grocery shopping, etc. And elderly.
Can you tell marital status? Because maybe in single adult households, this would be a more likely effect because you don't have a partner who can do the grocery shopping for you if you need to go to work.
I can tell marital status, but among the adults, the ones who you see as married is not very common. There aren't too many of them married people. And the other, I can also tell the gender. Actually, we did look at some of the results with gender, and we were seeing differences by gender as well. It didn't make it into the paper, but yes.
Which gender was more like?
Females were the ones who were delaying it. But also they were also we have more females.
Yeah.
And our males are very different than our females.
Yeah.
That's why kind of we chose, because more males here are disabled, etc. And the younger the children, you see the males, and among the children there's a much gender difference. And you know most Medicaid recipients who are female in this group, and they are going to be very different than the males we see. Okay? Yeah. But anyway, this is I think confirming the intuition we had, and we do see long wait effects for the elderly, not elderly, older adults. I mean, including my in-laws, I get a lot of grief about it. Again, I'm playing the foreigner card. I don't have a better word. All right, older adults. Okay, so older adults seem to be having the impact we were thinking we should be seeing. They are the ones who are not adhering to their medications. They may be the ones who are also more food insecure too. They may not have the same kind of support system. Younger adults may. Kids may be getting food through school. You know, they have their free lunches, etc. They may not have access to that. They may not be mobile enough to go to soup kitchens or go to pantries. So they are the ones who actually experience long wait effects, okay? Farther away than they are from their benefit day, more emergency room. We see them in the emergency room more than expected, okay? All right, yes?
Or is the older group in your data also more likely to be disabled, just because I would imagine they're getting benefits less because they have children and more because...
Yes,
so
they were, I don't remember the numbers now, but yeah.
It might be, I mean, you've probably done this, but looking at whether they had a disability or not, and
Yeah.
looking at that, because it could be like a composition of...
Okay, that's a good idea. Yeah, I don't remember the numbers, but yes, you're right. It's probably very likely that's the case. Yes. Yes. Yeah. I'm trying to remember all the categories we had for, you know, because we know why they are qualifying for the Medicaid. Yeah, I should go check that number. All right. So next, I want to think about alignment of the. So remember the picture I showed you for August 2005? We had the long waits at the beginning of the month and at the end of the month, right? So we believe people who are experiencing their long waits at the beginning of the month are going to have a very different experience than people who are experiencing it at the end of the month. So basically I'm talking about two groups. Group whose benefit month aligns with their calendar month, or with all the other income sources they might have. So people who are receiving at the first of the month with everything else, their TANF, their disability benefits, their salaries, etc. at the beginning of the month. How they are how constrained they are at the end of the month is going to be very different than someone who is getting it on the 10th of the month. All right?
So all the other benefits in South Carolina are arriving on the front.
Not only in South Carolina, most benefits everywhere are distributed at the beginning of the month. Yeah, yes. So this is the next part of the story. We are going to try to understand how that alignment, misalignment of benefit, or SNAP month in this case, with the calendar month affects the results that we are observing. Okay, so long wait results. So this is the stylized facts I was just talking about. Most income and income-related benefits come at the beginning of the month, all right? And income availability cycle is something people talk about, and this affects low-income households a lot. And so the question, kind of natural to ask, is: are there any calendar cycle effects, or are there any effects that's coming through this misalignment or alignment? All right. So we know from the literature there is more. And I'm talking about now end of the month, not end of the benefit month, emergency room use, or emergency. In the emergency room, you observe the low-income populations more at the end of the month. And Women who receive their SNAP benefits later in the month are less likely to receive pregnancy-related care in emergency rooms, meaning they are less likely to be in the emergency room for pregnancy-related complications. This is from Heflin. Heflin actually wrote a lot of papers on this for all different conditions. All right. And in a different paper recently, this is a working paper, it's a great paper if you are interested. They are looking at the SNAP and TANF benefit timing. This is from West Virginia, and opioid misuse. Okay? And remember West Virginia, the last names have, and also remember West Virginia in general about. If you ever have time, watch the documentary Wild Whites of West Virginia. It's an awesome documentary. It tells you everything you want to know about West Virginia. I hope there's nobody from West Virginia. Yeah. If there is, I'm playing the foreigner card. Okay, so we kind of know that there exists some issue with the calendar months as well as the benefits months. Okay, so as a result, what are we going to do? We're going to try to distinguish people who are whose benefits are aligned with their other incomes. All right? So these are the long waits that are experienced at the end of the month. So these are the people who are receiving their benefits early on. Okay? So, and these are any long waits. This is the original definition. I showed you the results. So that was the number, remember. And when you look at the people who receive their benefits with everything else, experiencing their long waits at the end of the month, where we know there already is an effect, that is the effect for them. They do appear in the emergency room more than what we expect if we are looking at the people who are, whose benefits are aligned with their calendar months, okay? So that is, again, confirming maybe the smoothing story a little bit for us. All right, and this is also something you wanted to look kind of deeper with the age groups, and you can see the most affected groups are whom you expect to see, elderly, but also the prime-age adults who are more likely to be parents. And we are thinking the story for them is not necessarily the same reason for like the adults, the older adults, but it is the maybe them distributing resources differently in their households. You know, kids eat, they don't. They may be the ones who are cutting, you know, their share of the resources. And the other thing that was kind of interesting was this result. I mean, it's not significant, but you know, why there is negative. Remember the negative that we were seeing at the overall thing? We are thinking, and one of the referees told us to look into, and we did, and that group may be taking up extra work at the end of the month. They may be working more at the end of the month and not, again, seeking medical care. We looked at the American Time Use data, and we do have some evidence that they do in fact work more at the end of the month in states where the distribution is at the beginning of the month. So again, we can only say something about average, not individual. All right. Okay, so I'm done.
You're pretty much done.
All right, I'll be done.
Yeah.
I have some, and if you're interested, I will tell you more about this. We did some extra work with Nielsen data to understand, do people actually smooth or not? And I will show you all these results later if you ever want. But we did for this particular work some additional analysis by expanding the data into the form that you would ideally would like to have. So we generated a panel by blowing up some 1 month of our data into a true panel. Not only incidents that we see, but all the other days we don't see them in the emergency room. And did some, you know, straightforward panel analysis, find the same results, confirming what we found. And basically, what you take out from this, food scarcity matters. Okay, we do have some older adults suffering from scarcity of food, possibly delaying their medications, etc., ending up in ER more. some of the emergency room use for this group is discretionary, not really through emergency. And what else I want to say here is, I'm not going to say anything more. I'm going to say thank you, and if you have any questions, I'll be ready to answer.
So we'll be around for a few minutes if
Yes.
folks have questions to answer. Next week, Stephanie Cellini will be visiting us from George Washington University to talk to us on an education topic, the graying of student loan debt. So we'll see you next week.
All right.
Thank you.